Hey guys, thanks for joining me. We are finally onto our section on circulation. This is our fourth, maybe, iteration of our TCCC March algorithm that we're working through as we go through our curriculum here. This is an exciting one. I think it really starts to put some of the medicine in, some of the decision-making skills in. Circulation is a huge section, so we're going to get right into it. As you can see, I'm not in my backyard. I'm actually at work today, but I'm at sort of a lower acuity place, and so I have some time to break away and film these because I want to get them out before drill weekend. I will be at drill weekend this upcoming weekend for the first weekend of February, and so I'm excited to see you guys, excited to hear what you have to say about kind of the curriculum and what we've been doing. So we will get right into it. As previously, I have no financial disclosures. I'd really love some. If you have somebody who wants to send them my way, send them my way. The only disclosures that I do have are this is my opinion. This is my opinion based on what I think is pretty good objective synthesis of the data, but that data is other people's opinions. And then it's how I view the data, which is subject to my own bias and whatever. And then a lot of it is based on my experience. My experience is my experience. It cannot be extrapolated to anybody else, but I think it's pretty good for what that's worth. But I would say for you, it may not be totally applicable to you, so use your own judgment. And if it doesn't fit your work environment, then it doesn't fit. All right. This is our first foray into real medical decision making. This is where, quote unquote, the real medicine starts. I think for most of TCCC, the other things are quite binary, but here you started getting into IV versus IO access. You start to talk about blood products, what blood products, how many blood products, what are my endpoints, tourniquet conversion or not. And then here is where you really start to see your skills. We are trying to make thinking medics. We are not trying to just make people who just do what they're told. We're trying to be able to teach you how to run your own resuscitations. That's the whole reason for this course. If that wasn't my purpose, we would not need to do these lectures all the time. But our goal is to have you be able to make these decisions and not just sit around and waiting for someone to tell you to make decisions. Okay? Here's what we're going to talk about. We're going to talk about the path of, we're going to basically take the guidelines as they come. This is a little bit set up different than the other lectures. The guidelines in circulation are quite straightforward, and I'm basically just going to show you the guidelines. They're going to be on slides that are the same for every slide, and then we're going to just talk about those essentially word for word as quickly as possible. And then if there are things to talk about in them, things I disagree with, things I do agree with, the pathophysiology, some literature supporting or maybe even refuting some of the guidelines that we talk about, and then a couple times we'll talk about how to perform some of the interventions. Okay? So our first guideline, the overall goal of circulation will be keep the blood where the blood should be, inside their body, hopefully in their vessels. And then the second overall goal of circulation is give them blood. If they have less blood than they should have. If you can only remember two things, remember those. Okay, here's our first guideline. So first guideline in the circulation section is on bleeding, and it says place pelvic binder for suspected pelvic fracture, or if severe blunt force blast injury with one or more of the following. They have pelvic pain, they have any lower limb amputation or near amputation, an exam finding suggestive pelvic fracture, which would be like unstable pelvis or severe bruising around the pelvis or perineum, unconsciousness or shock. And that's straight up the guidelines. Put the pelvic binder if you think they have a pelvic fracture, the end, done. Doesn't say what kind of pelvic fracture, doesn't say how bad, different styles, different grading systems, doesn't matter. If you think they have one, put it on. Why do they want you to do this? The pelvis is a huge problem, okay? This is just the arterial on your left and then the venous system on the right in the pelvis. So it is a watershed area in the body where you have major arterial and venous vasculature in close proximity to each other, and it is associated with lots and lots and lots of damage, especially in combat trauma. And the goal of the pelvic binder is to hopefully bring your pelvic fracture fragments together to stabilize any bleeding that is there. The problem with pelvic bleeding is that, like in the TCCC scenario, tactical field care scenario, it's very difficult to control internal bleeding. You cannot apply a tourniquet to it. You cannot apply wound packing or anything to injuries deep within the pelvis, and you can bleed a ton into the pelvis. Okay, pelvis is one of the main areas where you can lose a lot of blood. You can lose blood in your chest, in your abdomen, pelvis, thigh, or on the ground, and the pelvis is one of those. And so you can lose lots and lots of bleeding in there, and it's very easy to see like why that's possible. You have the iliac arteries here. You have the major venous arteries here. And then on the back of the sacrum here, you see this venous plexus prone to heavy, heavy bleeding for sure. How big of a problem are pelvic fractures? You know, I'm in combat. I'm a warrior. I'm not an old lady who's going to fall down and break their pelvis. Does this actually matter to me? They studied it. Jana Davis, Daniel Stinner, and James Bailey all studied this, and they published it in the Journal of American Academy of Orthopedic Surgery in 2012. They studied combat trauma in Operation Enduring Freedom and Iraqi Freedom. They took trauma data from 2008, and basically they said that 26% of people who died in Operation Enduring Freedom or Iraqi Freedom had pelvic fractures. And so basically there is a direct correlation between dying and having pelvic fractures in combat trauma, and that's what all the other data has shown. So if you have pelvic fractures, your injuries are automatically worse than other people's. We saw this the most in either mounted IEDs, so IED within a vehicle, or especially dismounted IEDs. You step on a pressure plate or something like that, you're going to have concomitant pelvic fractures, and it really increases your injury severity score. Pelvic fracture, super bad for you, super big problem in combat trauma. Okay, how do pelvic binders work? This is a pelvic binder right here on an actual trauma patient. It took a while to find one that was censored, but we found one. So pelvic binders work by basically taking your fracture fragments out of your pelvis, bones that are all shifted and broken apart, and stabilizing them, squeezing them together so they don't move around. It's not a cast, and it's definitely not a tourniquet. The goal is to not allow any hemostasis or blood clot formation that has happened in the pelvis by your body's own natural hemostasis to shift around. Think of it like the pelvic binder prevents the scab from being ripped off your knee or whatever. You rip a scab off your knee, you're going to bleed. Well, if you have a big clot in your pelvis that your body is trying to prevent you from bleeding to death from, the pelvic binder will prevent your fracture fragments from moving around and shearing that clot open and then just starting the re-bleeding all open again. Don't make the mistake that everyone makes initially, which is, well, I put the pelvic binder on so they're not going to bleed anymore. That's ridiculous. This is not a tourniquet. Don't think like that. Put the pelvic binder on, and you need to keep going because that alone will not save them. And we'll talk about that at length later. Okay? Where do you put the pelvic binder? You put the pelvic binder on your greater trochanters. We can talk about that more in person, certainly. But it's not at your belly button. It's not where your belt goes. It's lower than that. If you put your hands on your hips, up where your iliac crests are, and then you go down to your femur, where your bone juts out at your femur just below your hip, that is where the pelvic binder should go. It essentially goes, like in this picture, right over your genitalia in the middle, and you can cinch it down. I can show you guys cool tricks about how to use 2 tourniquets and a SAM splint to make a pelvic binder, and that works just as good as the commercially available. I believe this is a SAM splint, or SAM, I don't know if it's SAM splint, but SAM company, people that make the SAM splint, made this binder too. All right. Do pelvic binders improve mortality? That's a great question. It's literally the first guideline in teachable C circulation. So let's delve into it. So this is a paper out of Germany. I don't know how to pronounce any of these names, but does pre-hospital applied pelvic binder improve patient survival? This was published in Injury, which I've never read, but this was a very cited paper when I looked this stuff up. So there was only 66 patients, which is not high, but we take what we can get when it comes to research, and that's why all research has some problems with it. Sick patient population, high injury severity scores, people were pretty sick. Half of the people got pelvic binders. Sorry if you hear something talking in the background, it's this chair back here. Half of the patients got pelvic binders. Of those half of them were placed incorrectly, which was very annoying. There was no mortality difference between the patients with pelvic binder placed and those without. There was also no mortality difference in patients who had pelvic binders placed incorrectly and those who had pelvic binders placed correctly. Blood product, hemoglobin, injury severity score were all more indicative of mortality than placement or no placement of a pelvic binder. So that's points off for pelvic binder. This paper was very consistent with other papers that said that pelvic binders do not improve mortality. Well, if they don't improve mortality, certainly they must improve bleeding or like less blood products or like lower need for angiography or arterial interventions. And so basically somebody looked at this as well. This is a little bit bigger paper. This was in Switzerland. It was 228 patients with pelvic fractures over 7 years. It was retrospective, as you see right there, a retrospective cohort study. So our, ears go up when we hear retrospective, prone to problems. But again, take what we can get. So this study basically characterized fractures on a severity scale, and then they looked at the placement of pelvic binders and did it change, blood pressure, heart rate, shock index, like transfusion requirements. And then the big one was really arterial angioembolization. That basically means an IR physician, interventional radiologist, went up the arterial system and blocked it off to prevent bleeding because the person was bleeding to death in an arterial way that could not be controlled by any other manner. Okay? It's done when people who are unstable and have arterial injuries, particularly in the pelvis. So when they looked at these people, these 228 people, the placement of the pelvic binder was not associated with any difference in admissions, systolic blood pressure, heart rate, shock index, lactate, transfusion requirements. So it didn't even matter how much blood they got. And it didn't change the need for arterial angioembolization or mortality. And they measured it at 48 hours, so 2 days after the injury, and up to 30 days. And so none of it mattered. The only thing that did matter was how bad their pelvic fracture was. That's the only thing that actually matters. So it doesn't matter if you place a pelvic binder for a very minor pelvic fracture or a pelvic binder for a very severe fracture. None of it really matters. I'm sorry if you can hear this like thing going off in the background. I can't turn it off because it doesn't belong to me. But bottom line, it didn't change anything.
Please start first.
So, what do I think about it overall? I think it's a shame that the pelvic binder has really poor data that supports it. So that's sad. I suppose overall I'm sad about it. But at the same time, put the pelvic binder on because that's what the job tells you to do. Orthopedic surgeons, trauma surgeons, the person you're going to send this person to, they're going to want the pelvic binder on. So put the pelvic binder on correctly. Recognize that it's not going to save them. Do the other things that they need for you to save them. Don't think you're going to put the pelvic binder on, walk away, pat your buddy on the back, and tell yourself another life saved. That's not going to happen. You have your work cut out for you if a person has a major pelvic injury. Okay? All right, let's move on. Okay, next guideline in the bleeding section is the big one, important one. We will kind of read it mostly word for word, and then we'll talk a little bit about it. Reassess tourniquet application. So you are no longer doing high-impact tourniquets. You are out of care under fire. You're out of the massive hemorrhage section. So expose the wound now. Evaluate if the wound requires a tourniquet. If you believe the wound does require a tourniquet, place now a deliberate tourniquet 2 to 3 inches above that wound and ensure that the bleeding is stopped. If the bleeding hasn't stopped, or if there's still a pulse, add a second tourniquet right next to it. Straightforward. If you determine that a tourniquet is not needed, remove it and note the time on a teachable C card. Note the time on the patient's face. Note the time on the patient's injured extremity, somewhere where someone's going to see it, where it's going to get to this patient to know what time they got this tourniquet. Limb tourniquets and junctional tourniquets should be converted to hemostatic or pressure dressings as soon as possible if you have 3 criteria. Okay? So the first line is important. Convert the tourniquets if possible. Now, the second line is just as important. They really need to meet these 3 criteria, or you're going to convert someone who's going to decompensate and die. 1, the casualty is not in shock. They are not hypotensive. They are not altered. They are not, diaphoretic and sweating with a heart rate of 150. Okay, so they are not in shock. If they have the possibility to be monitored closely, you're not going to throw them in the back of some host nation Hilux and drive 4 hours across Mali with no one with them. That's not the person you take the tourniquet off, okay? Tourniquet is not being used to control bleeding from an amputated extremity. If you take a tourniquet off an amputated extremity, you're wrong. You'll always be wrong. Unfortunately, that's too bad. That extremity always going to need to have tourniquet on. Make it deliberate, 2 or 3 inches above the wound if you can, so they have less limb ischemia than they need, but the wound is just way too high risk to bleed. Arterial spasm can happen and prevent bleeding from an amputated extremity, but that only is going to last so long. Okay? So if those criteria are met, you can take your tourniquet down. to a pressure dressing, and then apply your combat gauze and pressure dressing as appropriately trained. All right. Every effort should be made to convert these within 2 hours. Tourniquets are extremely safe on the musculature, the neurovascular bundle, all those things within 2 hours. After that, you start to have some problems, but if you can, convert them within 2 hours. Don't remove a tourniquet that's been over 6 hours unless you're basically at, I won't say a hardened facility, but you're at a facility with lab capability, surgical capability, close monitoring, and the ability to intervene for some of the things that can happen when you have prolonged tourniquet time. Okay. Expose and clearly mark all tourniquet times on teachable C card or the patient, whatever. Bottom line for me, I have no problems. The data is very clear. Tourniquets save lives, tourniquets save lives, tourniquets save lives, but take them down if you can. Cool. All right. Assessing for hemorrhagic shock. Once your bleeding has been controlled, they want you to assess for hemorrhagic shock with mental status and radial pulse. This is like the shortest guideline in this whole section, but it's kind of like the most nuanced. It might require like the most skill. So it's like, how do I do that? I sometimes feel like, okay, well, someone tells you, go assess their volume status. Like, dude, I don't know. Like, what do I do with my hands? So let's talk about pulse first. Where are you taking your pulse? Doesn't matter if I take a carotid pulse or a femoral pulse or a radial pulse or brachial pulse. Does that matter in terms of what their blood pressure is? They did a pretty good study out of the UK where they measured various pressures with arterial lines and got people down pretty low, which seemed kind of crazy, but and they were attempting to identify what is the value at which pulses in certain anatomic locations go away. So this study in the UK basically found that if you have a radial pulse present, a pulse here on the radial side of the wrist, the thumb side, that is probably always going to be a blood pressure of at least 70. So 70 to 80 was what they really found. Very few people had one in the radial pulse, had a palpable radial pulse below 70. Okay? When they did the femoral pulse, very few people had a femoral pulse below 50. So they regarded femoral pulse as a blood pressure of at least 50 to 70. And then when they did carotid pulse, nobody had a carotid pulse below 40. So if you have carotid pulse only and no pulses anywhere else, you are at least above 40. But if you only have carotid pulse, you are in a world of hurt. You really, really need to move. Okay? So that's pulses. If they have a radial pulse, that's not awesome. If they don't have a radial pulse, but they have the others, they're getting worse. If they only have a carotid, they're even worse. So if you don't have a blood pressure cuff, that isn't a reason to say you don't know the pulse. If you have a blood pressure cuff, great, but you're not always going to have one. All right. AVPU is a good classic interpretation of mental status. So this is an acronym for alert, verbal, pain, and unresponsive. So their mental status is great. They're alert. It's the best it could possibly be. Their mental status is less good. They're only alert to voice. Okay, so I talk to them and then they sort of like become arousable. That's not quite as good as being keenly alert. And then the third one is pain. So they're only arousable to painful stimuli, sternal rub, something like that. And then the last one is the worst one. They're unresponsive. Doesn't matter what you do. You yell them, shake them, you sternal rub them. They're unresponsive. They are not responding to you at all. All bad. Mechanism. How do I assess if they're in hemorrhagic shock? Well, if they got both their legs blown off and their right hand blown off, they're probably in hemorrhagic shock. If they fell and bonked their head, but they're altered, they're probably not in hemorrhagic shock. The mechanism just doesn't fit, okay? If they've been shot 12 times in the chest or they've been stabbed in the belly, they could definitely be in hemorrhagic shock. But again, if they, got into a baseball bat fight and they broke their wrist, okay, they're probably not in hemorrhagic shock. So the mechanism plays a big role. And then experience. Sometimes it takes time in this job to figure out who is secretly sick. It takes time to recognize tachypnea as a harbinger of doom. The person's breathing faster than they should. I'm kind of worried about that. Okay, one of the others is diaphoresis. If the person is sweating, like, that's not normal. Nobody can fake sweat. So just watch out for that. Okay, so pulse, AVPU, mechanism, and experience are all ways to think about who is going to be in hemorrhagic shock or not. Okay, we're coming up on our sort of 20-minute time cap. I'm going to go one more, and then we'll stop this video, and then we will pick up in part 2. Okay, so we're going to go one more because I want to move quickly, and Next guideline is IV or IO access indicated if a patient is in hemorrhagic shock, at risk of shock, or will need medications but cannot take the medications by mouth. They recommend 18-gauge IV saline lock is preferred. And if you can't get IV access, place IO access. Okay? Straightforward, simple. Get the IV. If you can't get the IV, get an IO because you need it. Lots of spots to place IO. Humerus, sternum, distal radius, ASIS, this anterior superior iliac spine, distal femur become a big, distal femur is a big popular one among EMS. Proximal tibia is nice during cardiac arrest because it's far away, and then medial malleolus, never actually seen one placed there, but that's technically an FDA approved spot. So lots of spots. No medication limitations. Any med you can ever think of giving to anybody that can go through an IV can go through an IO. There are some just physical limitations, some blood limitations. The blood limitations are, people will say the more blood you give through an IO, eventually just the marrow becomes congested with red blood cells. I have seen that happen. I have seen IOs failed after several units of blood. That's probably real. There are just some flow rate limitations, certainly. You're not going to be able to drip blood through an IO. You have to pressure bag it in. Then there are some legit complications, right? There can cause bone fractures, can cause osteomyelitis. If you don't recognize that there's a fracture more proximal to the bone you're placing it in, your medications can just infiltrate out of the bone or whatever. And so you put a distal femur IO in somebody who has a femur fracture, that's going to cause problems. And so there are some legit complications of placing IO, but generally it is pretty well tolerated. Here's some flow rates. Sternum, pretty fast. The fast one, I believe, is the brand name of the sternum one. It kind of lost a little bit of favor, but they're still floating around out there in the deployed environment. Humerus is the next most fast. Femur is between the humerus and proximal tibia. Like I said before, it needs to be on a pressure bag. This is a great foam website if you want to look at it, Rebel EM. But the IO needs to be on a pressure bag, or it's just not going to flow very quickly. And then if they're awake, it's not the drilling of the IO that hurts, it's the infusion of fluids into it. And so it can hurt, pretty significantly when they're awake. You can put a little bit of lidocaine in there, but that's kind of a more nuanced approach. You're putting the IO in because they're really dying. Okay, we're going to go for it on this YouTube video real quick, and that will explain how the IO works. How to do one, basically. I'm just gonna talk over this thing. So basically, they're putting in a humeral IO here, and they're gonna find the greater tubercle of the humerus, and they're gonna put this IO down. So basically, what you want to do is you put it down on the bone, and then you give it a little wiggle. He did it right there. That's literally directly what I do. I give it a little wiggle. I don't just gun. Okay, I don't just gun. Because what's gonna happen if you just go down, and as soon as it's through the skin, you gun. What you're gonna do is gunk up all that tissue along the needle, and it's going to get caught up and stuck in there. So don't just gun the second you stick it into their skin. You want to get down to bone, get on a flat surface, and make sure you're stable there. Here they are on the distal femur. They're going to do the same thing. They get 2 fingers up on the distal femur. Here's going to be proximal tibia. So everybody has this on the flat part of the tibia. Don't use the blue one in adult. That's just for infants, but these people are cadavers. So that's proximal tibia. Here's going to be distal femur. So here's what they're going to do. They're going to put it down. They're going to down to the bone. They're nice and stable. See how he didn't gun. Now he's going to gun. See how the skin got caught up there? And then what I tell people to do is I want them to lean into the IO. What I want them to do is when they're going to pull the trigger, it's not like a firearm where it just cracks off the round when a certain threshold is made. It takes, a slight bit of time for the gun to reach its maximum speed. So I gun, and then I lean gently onto the bone, and then as soon as it's through the cortex, I will let off the trigger. And then so he kind of kept going a little bit. The problem with that is if you're doing that on a baby, so unfortunate thinking, they went way deep on that one too. watch out for that, right? Because if you're doing that in the in the proximal tibia on an infant, on a combat trauma infant, and they got injured extremities or whatever, and you just gun right through it, you're going to go right through their tibia, fracture their tibia, and your access is blown. And so just watch that. Stop right there. So they went a little too much. Stop. They kind of kept going. They went another, 2 centimeters maybe. You want to stop as soon as it goes through that cortex. And then what they'll tell you is what you need to do is you don't need to put that. So put this thing on there, this tubing. You should be able to aspirate marrow out of that. When you pull back on that tubing, marrow should come out. The manufacturer will say you don't have to have marrow, but getting marrow back in the tubing has a much higher success rate of having the IO in the place that it needs to go. Okay, so aspirate back on that tubing, and you should get marrow in there. If you don't get marrow in there, really gotta watch that line and make sure that it's actually in there, because you might have some doubts about whether it's actually where it should be. Okay, so we are going to pause right here. We're going to stop, and we're going to go to part 2. At part 2, we're going to finish up talking about IO access. There's a cool new protocol coming out. We'll talk about TXA, and then we'll be a little bit about blood, and then we'll be done. Okay? Thanks, guys.